Hello, everyone. This is part two of the diabetes series. I'm going to talk to you today about the diabetes medication. So, if you're looking for the overview or complications, it's in another video. Let's first start by talking about the insulin. So, diabetics, especially type 1 diabetics, always use insulin. Now, granted, type 2 diabetics occasionally, as the disease progresses or during stressful or sickness, they might have to be supplemented with insulin. But however, mainly type 1 diabetics are the ones that use insulin with all their meals and at bedtime. With insulin, um, basically, there are four types of insulin, and then there's a combination therapy that sort of mixes different kinds. This is straight memorization. You guys have to memorize basically the type of insulin, what kind of medications or names of the medication comes in it within that class, and also the onset, peak, and the duration of each class. Now, I'm giving you a table of that in the next slide, and also with some onset, peak, and duration. But, on your resources, you're also going to have like some mnemonics that you might use or feel that they're helpful. So it's up to you how you kind of want to memorize this, but this is just straight memorization for the rest of your career. All right, so the first classification of insulin is rapid acting, and technically the most common will be Lispro, Humalog. Then you have short acting. This is your regular insulin. It's Humulin R, and you get that R, which kind of means that regular. Then you have your intermediate acting, which is usually MPH or Humulin N. You get that and from the NPH. And then you got your long-acting insulin, which commonly you see in the hospital is Detamir or Lavemir. Now, when we talk about the onset, um, basically what onset means is when does the insulin start acting up? Like when does it start functioning? When you talk about peak, it's when is the client most at risk for a hypoglycemic agent? When is the insulin at the most peak of its work? And that's when your client is going to be at most risk for hypoglycemia. And then when you talk about duration, we talk about how long is this insulin going to last in the body or is going to be working in the body. So it's kind of key to determine or differentiate those or define them, better say, for lack of better words. So that way, when you are memorizing these things like onset, peak, duration, you know what they mean. Oh, okay, the onset is when it starts working. Oh, okay, the peak is when basically it's going to be a higher risk for hypoglycemia and it's at the peak of its work. And then same with the duration. How long is this insulin going to last? All right, so here's the table that I was mentioning. Feel free to pause me so you can write this down or take a picture, whatever. So rapid, you're going to have an onset of 10 to 30 minutes. What this means is that if you're giving someone Humalog or Novolog, you need to have them be eating prior um, to you giving the insulin, or at least within 30 minutes of you giving this insulin, because it's going to peak at 30 minutes. And so if the client is not eating, they might experience a hypoglycemic event. The peak lasts until 3 hours, and the duration is 3 to 5 hours. Short acting insulin or regular, the onset is 30 minutes to an hour. It peaks at 2 hours, up to 5 hours, and the duration is from 5 hours to 8 hours. The regular insulin is the only insulin that can be given IV, intravenous. Okay, so make a note of that. It's the only insulin that can be given IV. And so this client right here, you need to be giving them something to eat or checking that glucose level to make sure that you are not crashing them within 1 hour or 2 hours. The intermediate acting insulin onset is 1.5 to 4 hours. The peak is 4 to 12 hours, and the duration is 12 to 18 hours. Now, this insulin right here, it's the only insulin that is cloudy. The other ones are basically clear. So it's distinctive because it's the only clouded one. Now, your long-lasting or your long-acting insulin, Levemir or Lantus is another brand name. The onset is 0.8 to 4 hours. It does not peak, so it doesn't have that risk of the higher hypoglycemic, time. And it also lasts, or the duration is 16 to 20 hours, 24 hours. Excuse me. Now, here's the interesting part about this long-acting insulin. You might have a diabetic that it's what we call a brittle diabetic, meaning their glucose is sort of very hard to control, and you might have them on rapid acting and long acting. Okay. Sometimes I've even seen diabetics with twice a day long acting insulin. Um, and typically, it should be given sort of at the bedtime time, basically during the day, bedtime, just because that way it sort of kind of controls overnight, and then your duration or that onset or it starts working in the morning when the patients are eating. But again, this is very individualized. Your physician typically decides, when the client, how much units they're going to receive. So it's not something that nursing decides. Now let's talk about in general about insulin. Well, it's given subcutaneous, with the exception of the IV regular insulin. So we never sort of give it in the muscle. It's always in the areas of the fat, and it's better absorbed in your abdomen. A lot of patients tend to tell you, "Oh, give it behind my arm." But, it's not that it can be done, but it's just better absorbed in the abdomen, in your belly, where your fat is. Here are some areas where you can give it. You can give it in your buttocks or your thigh as well. Now, careful with your thigh because, if you are exercising or you do run or do maybe some lifting weights, and you're working that muscle, then it's going to metabolize the insulin a little bit faster, and you could have those hypoglycemic events. So it's always important when you're giving a patient insulin or any diabetes medication, that they're educated to recognize the symptoms of hypoglycemia, and also um, that they carry a little simple carb, 15 grams of simple carb snack with them. You want to rotate the sides because it does lead to this lipodystrophy, from always injecting it in that subcutaneous tissue. And also you want to avoid any areas where there's a scar or an incision, and always inject it 2 inches away from the umbilicus area. Now, sometimes these insulins come on insulin pens. Not always you're going to see your vials at the hospital or your patient that just does vials. They might have an insulin pen that rotates, and you basically, um, uh, rotate the little dial and choose how many units the patient is going to have. Well, insulin pens are better for the clients with poor vision, or they might have dexterity issues or cognition and stuff like that. So, um, know that that could happen. Um, we want to store insulin on not very volatile environments. So, for example, insulin doesn't like to be very cold, like freezing, or very hot, like in the state of Texas. Um, uh, Weather of 100 degrees. So you kind of want to store it in a sort of room temperature, especially if your insulin is currently in use, and then refrigerate it if it's not in use. One thing that I want to talk to you about with medications is that when you are taking other medications, such as beta blockers, and beta blockers are medications that are given for your blood pressure or your heart rate, they slow the heart rate on a client. And so when a client is on a beta blocker, pretty much it can sort of mimic or mask the hypoglycemic signs and symptoms. So, one of the hypoglycemic signs and symptoms is tachycardia. But if you are taking a medication such as a beta blocker that lowers your heart rate, you're not going to be experiencing hypoglycemic tachycardia. So it's something that we want to educate our clients. Hey, if you're ever, taking a beta blocker that lowers your heart rate, know that, you might not experience this hypoglycemic sign that is tachycardia. Okay. And then another thing to educate our clients is that when you're sick, you never sort of want to skip your insulin dose. Um, when we're sick, it's very stressful in our body. Also, another thing is that infections specifically can increase your glucose levels in your body. So, if you have a type 1 diabetic, even though they're sick and maybe they're vomiting or not eating, you still want to give them their insulin. Same with type 2 because their glucose level is going to be higher. They're also instructed to monitor their glucose level more often and also check for ketones, drink lots of water, and contact the doctor if their symptoms persist or they have any signs and symptoms of complications such as abdominal pain, dehydration, persistent vomiting, or those ketones in the urine, or any glucose level that is not managed with your insulin or medication that goes above 250. So, those are some education points when you're talking about medications with a client. Now, let's get into your oral hyperglycemic agents. Now, before I talk to you about every single class, and we have 8 primary classes, I wanted to let you know that we have clients that, yes, they are in oral hyperglycemic agents and insulin. Now, these are going to be your type 2, or you might just have clients that are just on oral hyperglycemic agents, maybe 1 or 2 classes of this. So there's 8 classes, they're listed here. Some of them are a mouthful to pronounce. We have biguanidines, then your sulfonylureas, and then your meglitinides, You got your alpha glucoseidase inhibitors, your SGLT2 inhibitors, your DPP4 inhibitors, GLP-1 receptor agonists, and then this thiazolionidines, which are a really big mouthful. Don't feel bad if you don't know how to pronounce these or you struggle. I struggle too, so don't feel bad. They'll get better as you continue to practice. So let's start with your biguanonides. The most common that you're going to see in pretty much every client is on biguanonides, especially in the hospital. It's metformin. And it's basically your first line of treatment is the one that doctors like to prescribe as the initial treatment. Is also given for pre-diabetics. They sort of test the client with metformin initially just to see what the glucose level does. And again, we're talking about type 2 diabetics, not type 1. I keep reinforcing that because I don't want you to get confused. Basically, metformin works by reducing this hepatic glucose production. So it tells the liver, hey, stop producing glucose. But it also increases the sensitivity at the cell level, at the tissue. And so if we are allowing the glucose and the insulin to be absorbed or enter into the cell, then it's going to be functioning correctly. It also helps to lower lipids and lose weight. So some of the considerations that we need to educate our client on biguanonides is that it produces a lot of GI upset, with especially diarrhea. So it should be given with food always. You're going to have clients that complain of this diarrhea and GI upset, especially if they're eating a lot of carby and sugary foods. They have to run. They run to the bathroom. I actually have someone I know that says, in the morning when I take my metformin, I can't go out of the house for 1 or 2 hours because I know I'm going straight to the bathroom. Um, so a lot of sometimes non-compliant happens because of this. So we want to let the clients know, hey, listen, this is going to happen. The best way you can control it is by sort of lowering your carb intake and sugars, and just know that it's going to happen. It's part of the medication. You're not allergic. And please do not stop it because your glucose levels can go out of whack. You also want to monitor for lactic acidosis. Um, so kind of muscle pain and increased heart rate, that can happen. Um, Very, very important. We got to tell them that if they are having a procedure that requires IV contrast, like a CT or a pyelogram, anything that requires an IV contrast, they need to hold metformin for 1 to 2 days before the procedure and then 2 days after the procedures. The reason for that is because metformin can be a little harsh on the kidney, and contrast is harsh on the kidney. So we don't want to injure the kidney. And while basically we flush the contrast through the kidney, we want to hold the medication and we don't want to give it. So that is why it's not suitable for kidney failure patients, liver, or heart failure patients. The next one's your sulfonylureas. You got your glipizide, gluburide. They end in IDE or IDE. IDE. This is another common classification. And look how interesting this class is. It stimulates insulin production at the pancreas. So it tells the pancreas, hey, listen, stop working, don't be lazy, put yourself to work and produce insulin. So we want that. They're very effective. So because they produce more insulin, or it helps to stimulate that production of insulin, your client is going to be at higher risk for hypoglycemia. So we got to monitor hypoglycemia, and you want to take it within 30 minutes of, of a meal. So that way you don't crash the patient and avoid alcohol. Okay, your next one is your meglitinides. They end in glanides, so it kind of sounds like the classification. Um, the two most commons are listed up there for you. This one's they stimulate insulin production from the pancreas, but it does it quicker than your sulfuronides. Sorry, your sulfonylureas. See, I get trouble too. um, they still produce insulin and stimulates that secretion from the pancreas, but it's quickly, like very fast, faster than your other class. So here your risk of hypoglycemia is going to be higher, higher, higher. So therefore, we do not want to give it without eating or skipping a meal, and you need to give it within 30 minutes or right when you're eating. So here's your first bite of food, and here's your pill, basically. That's the main distinction between those two, the sulfonylureas and the um, McNilletides. Okay, your other one is your A glucoseidase inhibitors. These ones are called the starch blockers, and I do not have an ending for them. But what they do is that they slow down the absorption rate of carbohydrates in the intestinal tract. So instead of the intestines absorbing carbs like they normally do, it's just a slower process. And so that's why they sort of say that they're starch or carb blockers. They need to be taken immediately before eating, so that way it just sort of blocks that absorption of carbs. And then they can produce gas, abdominal pain, and diarrhea, so we monitor for that. Your next ones are your SGLT2 inhibitors. And just if you're wondering, this SG stands for sodium glucose co-transporter. And it's going to be your key to remember what these drugs do. Sodium glucose. Okay, what they do is that they block the renal glucose reabsorption at the kidney, but they also excrete glucose through the kidney. And so if I'm telling my kidney, hey, stop reabsorbing glucose and excrete more, then, my glucose levels are going to be a little bit more controlled. So it has to do with the kidney. So sodium glucose, maybe you can relate sodium and kidney. The higher considerations here for these classification is that because we are excreting a lot of glucose, glucose is pure food for bacteria and infections, okay? So it basically puts the clients at higher risk of infections, especially urinary tract infection. Not only that, if we're excreting and increasing the excretion of glucose, we're also going to be peeing a lot. And pee, if we're losing a lot of pee, we're losing a lot of fluid, water. It could lead to dizziness, dehydration, so to speak. So they're encouraged to drink a lot of water. And yes, it can cause hypoglycemia. If we're not reabsorbing it and we're excreting it more, then we don't have glucose in the body. So they are a risk for hypoglycemia. Okay, your next one is your DPP4 inhibitors. These end in gliptin. They work by inhibiting two incretins hormones that are sort of in your GI tract, which basically increases insulin production from the pancreas. As soon as we eat, our intestines release this hormones, incretins, and so that tells the pancreas, hey, you know, sort of increase or don't increase that insulin production. So by inhibiting them, we do increase the insulin production. So mainly it's after eating. But it also tells the liver to do not produce glucose. So they kind of work in the liver and they also work in your intestine, GI, so to speak, tract. Okay. The consideration for these are that you have less risk of hypoglycemia because again, it has to do with your eating and you're inhibiting this hormone. So therefore, um, you kind of not have the risk of the hypoglycemia more. Um, but it also sort of helps with not regaining weight. And let me explain what that means. It's not that they're going to lose weight, but if you're at a weight of, let's say, 200 pounds, you might not gain or regain more weight. Um, it's not that you're going to lose, but it's just you're not going to gain more weight because a lot of this the hyperglycemic agents, um, they tend to produce weight gained by a sort of rebound effect because it makes the person eat more. Um, but in this case, it doesn't. Now, they are a higher risk of pancreatitis and allergic reactions, so you kind of want to monitor the clients for that. Then you have this classification, which is a mouthful to say. Let me try it. Lidoniodines, something like that. um, they end in dizone. They're called the insulin sensitizers. Basically, these are best when clients are resistant to insulin at the cell. It basically increases insulin sensitivity, transport, and the use at the cell. So it basically helps at the cell saying, um, okay, yeah, come on, insulin, you can bind to my lock. The key can bind to the lock. I'm going to transport it and I'm going to use this basically insulin so that way I could accept glucose molecules. So it works mainly at the cell. Some consideration, there are less risk of hypoglycemia. They can cause edema and weight gain. And a big warning is that they could cause bladder cancer, heart failure, MI, and stroke. So some cardiac issues there. So therefore, they're not very commonly used. Not as, well, better say, not as common as the other ones. And as a matter of fact, I think there was a lawsuit going into Actos, but I'm not sure. Then you have your GLP-1 receptor agonists. These stimulate the production and the release of insulin. They decrease glucagon secretion from your pancreas, okay, which converts into glucose, um, and also slow gastric emptying. Now that's going to come handy because when you are slowing your GI tract and it holds on to food longer, that means the clients feel fuller and you feel like you're not hungry all the time. And therefore, these type of medications are also kind of being given now for weight loss. Most of them are subcutaneous, like a once a day injection or twice a day injection, because it stimulates the production of insulin. They are a risk for hypoglycemia, and you kind of want to monitor nausea, vomiting, and diarrhea. I have a friend that recently got some surgery, and the my friend is taking this medication in order to maintain that weight and not gain weight, or perhaps even lose a little bit more weight because it makes you feel full and not eat all the time. All right, as always, my references are from our book, and all images are obtained from Google or the book. I hope this was helpful, and I will see you on part 3 of the diabetes series. Bye bye.